All right, so this one tonight is going to be freehand, right? If you were on this morning, had a little presentation prepared on APGAR score. This one's going to be freehand just because that's the way my mind works with drug profiles. Is just kind of pushing our way through a variety of medical terminology, anatomy and physiology, and everything. So we're just going to have effectively a whiteboard conversation through this one. And as questions come up or anything like that, feel free to chime in. Probably easiest in the chat box, but whatever works for you. All right, so the ones tonight that we're looking at are going to be, in terms of the drugs, right? We're going to do Albuterol. We're going to do Ipratropium Bromide, or more commonly called Atrovent. And then we're also going to talk through really kind of a twofold option. One of them is Methylprednisolone. It's actually methylprednisolone sodium succinate. And the other one is Dexamethasone, sodium phosphate. Right? And both of those, we'll talk about them together just as steroids. Right, so looking at it just kind of as that initial starting point, right, we're obviously talking about airway management, right? We're looking at kind of the classic difficulty breathing, bronchoconstriction, asthma exacerbation protocol for it. So it's kind of, dependent on exactly how it looks or is laid out for you, whether you're using like Red Book or the Arizona DHS's T3G protocols, or you have a different set of protocols from somewhere. Most all of those general difficulty breathing, bronchoconstriction, difficulty breathing algorithms really start with, most commonly the 1-2 punch of albuterol and Atrovent, followed potentially by a steroid. Some agencies use magnesium sulfate, or really bad non-responsive asthma exacerbation to any of these other drugs. They might try epinephrine. So a lot of different options, but this is really going to be kind of the starting point foundation for it. So the first drug we're going to cover, albuterol. Look at a clean slate. Albuterol, or as a lot of people say, Albuterol, right? It really works well, right? It's a very good drug in terms of, patients responding to it, right? It's kind of the typical one that patients have their metered-dosed inhalers, is it contains albuterol. So we carry it, generally it's packaged at a higher concentration, which is why somebody could be taking their asthma puffer, right? Their inhaler, their metered-dose inhaler, their albuterol, but it's not working, right? And then we come along, we give them our albuterol, and they're like, man, this works so much better. It's usually a higher concentration. We also nebulize it with the 100% oxygen. So there's a couple different reasons why it can start to work better for us. Okay? But with albuterol, right, if we're looking at drug profiles and just starting kind of square one back to the beginning, is we look at what class is the medication. Because everything, starts to make sense when you go all the way back to just what type of medication is it, right? What is that class? And then that class's medication, then we know based on that class, here's the mechanism of action or how this medication actually works in the body. And then once we understand how it works in the body and what it does, then we can see where it makes sense for what we're going to be treating, right? And then figure out the doses and everything from there, right? So it all starts with class. One of them is a bronchodilator, right? Bronchodilator, and that it's dilating the big bronchi, right? And the second one, which is where we're going to spend a little bit more time talking, is that it's a sympathomimetic. Sympathomimetic. All right. real fast. I got one chat comment. Can you guys see my screen? Me writing? Okay, cool. Thank you. All right. All right, so sympathomimetic, right, for the class. That's the one that we're really going to look at, right? Because the bronchodilator aspect of it is really a little bit just kind of secondary to the fact that it's a sympathomimetic, right? So that's pushing us into the nervous system. That was actually quite interesting. We're going to start this conversation about pharmacology and respiratory medications like albuterol and how it opens up the lungs. But we're really going to go into the anatomy, really the physiology or the structure of the nervous system that's going to actually dictate it. Right? So sympathomimetic means it's mimicking, right? Mimicking the sympathetic nervous system. Right, the sympathetic nervous system. So it's mimicking the sympathetic nervous system. Right? And sympathetic nervous system is also known as, right, the adrenergic nervous system. Right? So the adrenergic nervous system is the sympathetic nervous system. In terms of our textbooks and everything, we really spend the vast majority of our time talking about it as the sympathetic nervous system, and less so do we use that word adrenergic. Right? But sometimes they'll talk about that in terms of the receptors and how this medication is actually going to work, is they'll use that adrenergic word. Right? Most commonly though, right, well, you've probably heard this is the fight or flight response, right? Fight or flight response. Or increasingly what people are saying is the fight, flight, or freeze, right? Because some people, when they have just that massive stress reaction, they just freeze. They lock out, right? They don't do anything, right? So more classically, fight or flight, increasingly fight, flight, or freeze. Also sympathetic nervous system, also the adrenergic nervous system. Right, so when we pull up some of this terminology, we can kind of piece together, or at least start to piece together, what hormones are being released, right? What endocrine glands are we talking about here? And how are those controlled by the nervous system, which is ultimately going to manifest with these respiratory changes that we want to have happen for this difficulty breathing patient. Right, so we have a little bit of nervous system, a little bit of endocrine system, and ultimately the respiratory system, which is where we want to see these effects actually happen. Right? So getting into the sympathetic nervous system, right, we're going to take that step back and just kind of lay out the flow of the whole nervous system. Right? So if we're looking at the entire structure or layout of the whole nervous system, right, for starters, it's either the central nervous system or the peripheral nervous system. Okay. So central nervous system is our brain and the spinal cord. Okay. So central nervous system is brain and spinal cord. Peripheral nervous system is everything else, right? All the other nerves, right? The motor nerves going out to our muscles that allow us to get up and walk around and write and everything. And the sensory nerves that allows us to actually process, hey, it's too cold outside and I need to let my brain know about that so we can start making some changes to actually start to warm ourselves up, right? Or vice versa, it's too hot outside. So we have those sensory nerves that are monitoring kind of the outside environment. And then we also have the sensory nerves that are monitoring the inside environment as well. So we have motor nerves and sensory nerves. All those are peripheral nervous system, and the central nervous system, again, is just the brain and spinal cord. So peripheral nervous system, right, there's actually two options, right, or two kind of subcategories. Right? On the one of them, we have the somatic nervous system. Right? When we see soma, you should think muscles, right? Like soma is a drug, a medication, right? Soma is a muscle relaxing drug, right? So when you see that soma, I want your minds to think muscles and a touch more specifically our skeletal muscles, right? So our big, skeletal muscles, right? So we have conscious control over our bicep muscles, right? As we can send that signal, say, hey, I want to bend my arm because I'm going to, lift up my glass of tea here. And in order for me to do that, my brain is going to send that signal down the spinal cord, which is going to exit a motor nerve out to that muscle, which is going to stimulate that muscle to depolarize, and it contracts, right? So somatic nervous system is all of those skeletal muscle control, right? And like I said, those are the ones that we have conscious control over. So people will call this the voluntary nervous system, right? Voluntary nervous system, okay? So again, if you want to activate any muscles to stand up, walk, play piano, type on your computer, anything like that, that's voluntary control, right? You're choosing to do those things. And it's done so by activating those skeletal muscles, right? And we call that the somatic nervous system, or at least that branch of the nervous system, which is voluntary. Now, the other side of it, right? The other side of it is the autonomic nervous system, right? And autonomic, you should think is automatic, right? Autonomic is automatic. So it is the involuntary nervous system, right? It's all of those things that we want our body to keep doing, but we don't want to expend the mental energy to have to keep consciously thinking about it all the time, right? So our brain's control to send that electrical signal down to the diaphragm so that our diaphragm keeps breathing when we're asleep and we don't actually have to think about breathing, right? Every, 5 seconds that we want to take a breath, we don't have to go, oh, wait, I need to breathe. Okay, there I go. All right, 5 seconds later, oh, wait, I need to breathe. All right, there I go, right? So these things are all happening automatically in the body. Same thing with our blood vessels, vasoconstricting, vasodilating, our bronchi, bronchoconstriction, bronchodilation, right? Tons of automatic, involuntary control functions in our body, right? That we don't want to have to think about every single, second of every day. Right, so the autonomic nervous system is involuntary. It's all those things that our body is just doing on its own that we don't have to consciously think about and consciously control. So the autonomic has two subcategories as well. We can kind of start to see the branches that are showing up here. And on the autonomic nervous system side, the split is our sympathetic nervous system, right? Our sympathetic nervous system. All right, so I need somebody there. All right, our sympathetic nervous system. And then the other side of it is the parasympathetic nervous system. Okay. So then, like I said, sympathetic, right? Fight or flight, or fight, flight, or freeze, increasingly. And the parasympathetic, what a lot of people say is rest and digest, or feed and breed, right? Or I swear I figured it out one day, but I heard somebody else say it was sit and shit, right? It's the kind of more long-term life-sustaining functions, right? The sympathetic fight or flight response is that's being activated to try to keep us alive right this very second, right? We're walking down the street, we see a lion chasing us, right? Our body has a massive stress response, right? Where we're going to start to, our heart rate's going to increase, our blood pressure is going to increase, right? Our body is ramping up to either fight this stressor or run away from it, or we just have the kind of over-the-top stress reaction and we just freeze, right? We lock up a little bit, right? So that sympathetic nervous system, fight or flight, that's acute, that's happening right now because of this stressor that we need to deal with, right? And we need to do something about it, right? I know a lot of students, if I told you, hey, you're going to get up and give a hour presentation to the class next week, right? You're going to do it, right? A lot of people are like, oh my gosh, that's not a lot of time for me to prepare, or oh my gosh, I don't do public speaking. I am not going to do that at all. They have that stress reaction, right? That's the sympathetic nervous system getting triggered, right? The parasympathetic, again, that's the other systems, right? So our ability to rest, right? Our GI system's ability to continue to digest food, our reproductive system, right? If we thought about a lion coming down the street chasing us, our body really shuts off blood flow to the reproductive system and says, that's not something you need to think about right now. You've got much bigger problems at hand, right? You've got this lion chasing you, right? Same thing, the blood flow to our GI tract to help us digest food. It's like, well, we're digesting food right now for later, right? We got to deal with this stressor right now. So I need all the blood flow I can get to help me redirect stuff to the big skeletal muscles and everything, right? So it's really that that kind of piece together of where does the body need blood flow right this moment, right? And the sympathetic nervous system says, I'm going to shunt all of this blood to my core, right? The important stuff that I'm going to need to stay alive, and my big skeletal muscles so I can go run away from something, right? And so it shunts it away from the reproductive system, the GI system, right? A lot of those body systems, the body really pulls the blood away from it, right? In that priority determination, right? That priority decision that's there. All right. Yeah, that's a massive over-the-top stress reaction there, Edward. All right. So these are the branches down, right? And going back to albuterol, right? We said albuterol is a sympathomimetic, so it's mimicking the sympathetic nervous system. So this is where we're falling on nervous system regulation for how albuterol is actually going to trigger the respiratory effects that we want to have happen, right? Because everything gets controlled at the end of the day by the brain, right? So everything else is a response of the brain sending the signals out, doing the things that it decides it needs to do, right? So on the medical terminology side, when we look at the sympathetic nervous system, it said it's also called the adrenergic nervous system, right? Adrenergic nervous system, right? And a lot of people, when I say that fight or flight response and say, hey, what substance, what chemical, what hormone gets released in the body when you have just that massive fight or flight response and everything gets ramped up and the blood flow gets increased and your heart rate increases and blood pressure increases. And a lot of people will say, that is a whole lot of adrenaline coursing through the system. Right? And you can see it's in the name, adrenaline, right? So adrenaline is that hormone, right? It's one of the principal hormones of the sympathetic nervous system that gets released and floods throughout the body that does a lot of those things that I'm talking about, right? Where it shunts blood away from certain structures and certain body systems, redirects blood flow to other ones, increases heart rate, increases blood pressure, all of those things, right? So it's this big adrenaline release throughout the body, right, is what it is. And when you look at the word adrenaline, we see adrenal, right, which is telling us where this chemical is actually coming from inside the body. It's being released by the adrenal glands, right? So adrenergic, adrenaline, adrenal glands, right? We can just kind of keep going with that terminology there, right? Now, adrenal, right? Adrenal, if we separated that, and we had ad and renal, right? Renal really references the kidneys, right? And ad is really on top of, right? On top of, outside of a little bit. So adrenal literally means on top of the kidneys, right? And if we had a picture of it, right? If that's one of your kidneys, right? There's a little pyramid shape on top of the kidneys, and that pyramid shape on top of your kidneys is your adrenal glands, right? Is your adrenal glands. So adrenal glands is just saying it's a gland that sits on top of the kidneys, right? So the adrenergic nervous system releases adrenaline from the adrenal glands, which are sitting on top of the kidneys. Now, a lot of things in medicine, when we start going through it, and certainly medical terminology, it just wouldn't be fun if they didn't have just multiple names for the same thing, right? Just lots of different ways to call the same thing, right? Thank you. All right, so on top of the kidneys is where we're at. Another way of saying on top of the kidneys, right, is epi is on top of, right, or outside of, or around, and then the nephrons, right? And the nephrons are the actual component within the kidneys, right? Millions of nephrons, and those nephrons are the actual part of the kidney that's doing all the filtering, right? So on the anatomy and physiology side, the principal function of the kidneys, or one of the main functions of the kidneys, is to filter the blood, right? And so the nephrons are actually doing that work of filtering the blood, right? So the nephrons still really references the kidneys, right? It's that filtering unit structure within the kidneys, right? Just like if you go see a nephrologist, right? That's a doctor that specializes in the kidneys, right? So that nephron is really the kidneys. And the chemical that the kidneys release, another name for it, right, would be epinephrine. Right? Epinephrine is the same thing as adrenaline, right? Adrenaline, a little bit more common, probably layperson terminology, right? At least around here, more common layperson terminology. Epinephrine is more the pharmacological medical word that we use for it, right? But if you're a healthcare provider in Canada or the UK or whatever, and you go over to your drug box and you pull out the vial of epinephrine, you may see actually labeled on it, it'll say adrenaline. Right? So adrenaline is epinephrine. Right? So depending on where you are in class right now, as you're getting comfortable with it, the more we can frame medical words and medical terminology and anatomy and physiology to things that we know already, like adrenaline. Okay, adrenaline's a thing. It amps you up and gets you excited and everything. Right now, if you can link adrenaline with epinephrine, right, it'll help you as we keep getting into more pharmacology, right, and certainly more anatomy and physiology. All right. So I just like going through that kind of play on medical terminology of adrenal, right, adrenal and epinephrine, right, all referencing it's coming from on top of the kidneys, and on top of the kidneys are those adrenal glands. Right? So past that, the actual kind of workings of our sympathetic nervous system. Okay. And I promise you there's a method to the madness. We will be back to albuterol shortly. Okay. But the sympathetic nervous system is functions based off of hormones like epinephrine being released and binding to sympathetic nervous system receptors inside the body. Right? So sometimes we'll call those the adrenergic receptors. Right? Because the only way hormones and some of these chemicals can work in the body is if they actually bind onto that receptor, and then it stimulates, right? It triggers that cellular activity, right? Or triggers that reaction or that response by the body that has a very unique effect, right? So we have these sympathetic nervous system receptors, or these adrenergic receptors, and we give them kind of fancy names called alpha receptors, right? That's the shape for alpha, right? Alpha receptors, right? And we have kind of a B shape there, right? I'm actually gonna write it on the other side, right? And we have beta receptors, right? So we have our alpha receptors and beta receptors. Right? And we're going to do a slight split, and we're going to talk about beta 1 receptors and beta 2 receptors. We're going to talk about alpha just as a broad category. Right? The reality is there's alpha 1 and alpha 2 receptors that have slightly different things. We're going to keep it simple right now, though, and just talk about really kind of the one main thing that we're going to talk about with alpha receptors. Right? So alpha and beta receptors, specifically alpha and beta 1 and beta 2 receptors. Right? Now, the reality, like I said, there's alpha 1, there's alpha 2. I actually was reading one of the books that there's alpha 3 receptors, but they don't know what they do. It was an actual medical textbook, said there's alpha 1, alpha 2, here's what they do, and there's alpha 3, and we don't know what it does, right? So again, we're going to keep it simple and just talk about alpha. And when an alpha receptor, or sometimes they may say an alpha adrenergic receptor, gets stimulated, right, it causes widespread vasoconstriction. So again, simplified, right? We're going to keep it simple, right? When alpha receptors get stimulated, the response that they have causes vasoconstriction, right? So all our blood vessels throughout our body, right, vasoconstrict, right? Smaller pipes, right? So instead of big open blood vessels, we have much more constricted blood vessels, right? Smaller pipes. Right? And when we go back to that fight or flight stress response, one of the things that happens is our blood pressure ramps up. Right? And that increase in blood pressure is heavily influenced by this vasoconstriction. Right? This vasoconstriction that we have increases our blood pressure. Same thing if we were going into shock. Right? In shock, there's a significant stress on the body, whether it's a traumatic cause like a gunshot wound and they're bleeding out, or anaphylactic shock or cardiogenic shock. Any of those shocks are big time stressors on the body. The sympathetic nervous system gets activated. So when we're going into shock and that blood pressure maybe starts to drop, right, the sympathetic nervous system gets activated and it can help stabilize that blood pressure, help compensate for that issue, right? It's when we say they're in compensated shock is we're able to stabilize the blood pressure, and we can stabilize that blood pressure because of the vasoconstriction, or at least we're going to make an attempt to stabilize that blood pressure. So vasoconstriction with our alpha receptor stimulation. Now, again, like I said, if there was just one name for it, it wouldn't be as fun. Right? So we go through several different ways of saying vasoconstriction. Right? So we know vasoconstriction, right? The pipes are smaller. Another way that it can be phrased is increased systemic, right? Increased systemic vascular resistance, right? Or increased SVR. Ooh. Increased SVR. Right? So systemic vascular resistance. Systemic just means throughout the body. Vascular, talking about our blood vessels. And resistance, right? The smaller the pipes are, the smaller the blood vessels are, the more constricted they are, the more resistance there is to the blood flow actually trying to move through it. Right? So increased systemic vascular resistance says the pipes are smaller throughout the whole body, right? There's more resistance to that blood flow, right? So if it's not phrased vasoconstriction, maybe it's increased systemic vascular resistance, or maybe a touch bit less often is increased peripheral vascular resistance, or increased PVR. Right. Really the same thing, peripheral, right? Just referencing the periphery, the extremities, really a large portion of the body, right? Is it shunts away from the periphery, right? We shunt to the core, right? Because those blood vessels have constricted, which is again, just more resistance. It's more difficult to push that blood through, or it's going to take higher pressure of that blood moving through, right? So most commonly you'll hear me phrase it vasoconstriction, follow it up with increased systemic vascular resistance, and a little bit less often increased peripheral vascular resistance. But really we're dancing around that same concept of just saying we're vasoconstricting. So that's our alpha, okay, our alpha receptors of the sympathetic nervous system. And then beta 1 receptors versus beta 2 receptors, right? The answer is in the number for where we see the effects, right? Beta 1, we have one heart. So these are all cardiac effects. And beta 2, most of us have two lungs, right? So they're the respiratory effects, right? So beta 1, we have one heart, it's all cardiac effects. So one of the things that our body can do is it's going to increase our heart rate. Now again, let's pull us back to that fight or flight response, right? And that lion's chasing us down the road. You're like, oh my gosh, I'm gonna have to run away from that, right? So we go running, right? Our heart rate is elevating, right? The alpha response helped increase the blood pressure. The beta 1 response increases our heart rate. Increases our heart rate. Now, another thing that can happen is we're going to increase what we call cardiac contractility. Contractility. And contractility is how hard the heart's actually pumping. So a lot of times these concepts are going to go together, but we can talk about them as isolated individual terms and then think about their effect on things like blood pressure. Right? So if we said somebody's heart rate was 60, but the contractility, which is the strength of the contraction, maybe it was a very weak contraction. So we have a heart that's beating 60 times a minute, but that contraction is really weak, right? Versus a heart that's beating 60 times a minute, and that contraction is strong, right? The rate is the same, but the actual strength of that contraction is much, much, much different, right? So the harder that contraction is, right, the better that blood pressure is going to be. Right? The weaker the contraction is, the weaker the blood pressure, the lower the blood pressure is going to be. Right? So we can talk about increasing the rate, and we can also talk about increasing how hard the heart is pumping. And then there's one last one, which is tied into really how the heart actually functions in doing this, which is the heart's driven by that electrical conduction system of the heart. And so we can actually increase the speed or the velocity of, we'll call it electrical conduction, okay? Electrical conduction, okay? Which is really just saying how fast is that electricity moving through the heart, right? On another day when we do rhythm identification cardiology and we talk about that SA node depolarizes, that electricity travels through the heart. Right? So how fast or how slow that electricity travels through the heart is going to have an impact on how strong that contraction is and how fast we can start firing. Right? But we can talk about them again just individually. Now the nice part is in the fight or flight response, all of them happen, right? All of them happen. Our heart rate increases. It gets stronger, the electricity moving through it is faster, our blood vessels are also vasoconstricting. The beta 2 lung effect that we're going to talk about in a second, that one also happens in that fight or flight response because that adrenaline, that epinephrine hits all of these receptors. It triggers all of the responses. Right? That's why we have such that kind of amped up stress phase of the body. Mm-hmm. So increased heart rate, contractility, and speed of electrical conduction. But again, and if I'm not redundant enough already tonight, they like to give us more names to talk about those. Okay? So when we talk about the rate, right, and increasing the heart rate, they may use a term like a chronotropic effect or chronotropic effect, right? Chronos, the root of that is time, right? So chronotropic effect, a positive chronotropic effect is the heart is beating more times every minute, right? The heart rate is increasing, right? A lot of watches, right? If you flip over your watch and look on the back of it, it may say chronometer, right? Which is a device that measures, that's what meter is at the end of it. It measures chronos, time, right? A watch, a fancy name for a watch is a chronometer, right? A device that measures time. So that's a chronotropic effect. And again, if we're talking about increasing heart rate, that's a positive chronotropic effect. If there was another medication that acted this way to decrease heart rate, it would be a negative chronotropic effect, but we don't talk about that one too often. Contractility is the inotropic effect. And so a positive inotropic effect is going to be increased contractility or increased strength of that contraction, how hard that heart muscle actually contracts, is the inotropic. And then the last one, the electricity moving through, is the dromotropic effect. And dromos, as a root word, is running, right? So it kind of makes sense when we think about the electricity moving through the heart, or how fast the electricity is moving through the heart, or how fast that electricity is running through the heart, right? So chronotropic, inotropic, and dromotropic are the fancy names for increasing heart rate, increasing contractility, and increasing the actual speed of that electricity moving through. So all of those are cardiac effects, and so they're beta 1 effects because we have one heart. Now, the beta 2 effect, we have 2 lungs, and when that receptor gets stimulated, it causes big time bronchodilation. Bronchodilation. So we vasoconstrict with alpha and we bronchodilate with beta 2, right? That's where most of the beta 2 receptors are located in the lungs, just like most of those beta 1 receptors are located in the heart. That's why we get that difference of cardiac effects versus the respiratory effects. Now, the reality is there are some beta 1 receptors in the lungs and some beta 2 receptors in the heart, but the bulk majority of them are separated that way, so it works and we're able to do kind of the descriptor this way. So beta 2 stimulation, or beta 2 receptor stimulation, causes widespread bronchodilation, which again, that's just helping open up our lungs, because in this fight or flight high stress situation, our body is like, I'm going to have to do a lot of work. And in order for the body to do a lot of work, it's going to need a lot of oxygen, right? So by bronchodilating, it's making it easier to get that oxygen into the body, right? And the more oxygen we can get into the body, the more we can keep all of the cells throughout our body happy and to keep the whole system running in this high stress, significant fight or flight response situation that we're dealing with. So beta 2 response, beta 2 stimulation causes that bronchodilation. Now that finally gets us back to albuterol, which is where we actually started this whole thing, saying albuterol is a sympathomimetic. It's mimicking the sympathetic nervous system. And the other class that we said is it's a bronchodilator. And it's a bronchodilator. And it does that because albuterol stimulates those beta 2 receptors. Right? It binds to those beta 2 receptors and triggers that response. And that response is the bronchodilation. Right? So when we look at a class for albuterol, oftentimes it will say a beta agonist. Right? And the word agonist just means it binds to that receptor and triggers the normal response. Right? So it binds to the beta receptors and triggers the normal response, which is bronchodilation. Right? Now we know specifically we're giving it for beta 2 because we want to get the respiratory effects of bronchodilation. Right? But albuterol will also bind with some of those beta 1 effects, which is why if you put a patient on albuterol for a little while, one of the most common things that we will see on our vital signs assessment is that heart rate starting to increase. Okay? And that's the albuterol binding to the beta 1 receptors causing some of these cardiac effects. Okay? We're giving it for the beta 2, but it also causes some of that beta 1. Right? So we get some tachycardia there with it. But the bronchodilation is our goal, right? That's kind of why we're here, right? We're dealing with the airway breathing situation. So that's why we're giving it. The increased heart rate comes a little bit secondary for us most of the time. Right? So beta-2 receptor or beta-2 agonist binds to those receptors, causes bronchodilation. Right? And when we look at bronchodilation, right, if we have the bronchi and bronchioles in our lungs, is wrapped around those bronchi and bronchioles are smooth muscles. Right? And smooth muscles definitionally constrict and relax to allow contents to move through it. Right? So wrapped around our bronchi and bronchioles in our lungs are these smooth muscles that constrict, bronchoconstriction, and relax, bronchodilation, to allow stuff, oxygen, carbon dioxide, to move through the pipe, right? Move through the tissue, right? So when albuterol binds to those beta-2 receptors, right, it causes this smooth muscle relaxation, right? This bronchial smooth muscle relaxation. And when those smooth muscles relax, those bronchioles open up, right? They open up and it becomes easier to breathe, right? Easier to get that oxygen in and out of the lungs. So indications for us, right? If we were looking at indications, okay. Indications are obviously any sort of bronchospasm problem or a bronchoconstriction problem, right? Kind of most often the phrases you hear like a bronchospasm, which is referencing the bronchial smooth muscles spasming or the bronchial smooth muscles constricting, so that we can give albuterol to bind to those beta-2 receptors to cause bronchial smooth muscle relaxation to open them back up. Right? So bronchospasm, bronchoconstriction, or really, we're looking at kind of the classic, asthma exacerbation. There we go. I can't spell tonight. Exacerbation. There it is. Asthma exacerbation. Right? So we see that, we manifest it most of the time on our assessment. Right? We determine that heavily based off of our breath sounds with wheezing. Right? Wheezing is telling us that air is moving through smaller pipes, right? Because those bronchioles have constricted down. So it makes a little bit of that higher pitched wheezing sound when we actually are listening to our breath sounds. Right? So that's one of them. One of the ways that we can help determine that. Another one is end-tidal carbon dioxide monitoring. We can look at things like waveform capnography, and that can clue us into how significant that bronchoconstrictive process might be. Right? Cool. So that's that. So one question just popped in here. Said, so albuterol is like Epi Junior, right? Very similar, but less potent. Very similar when we go back here, right? Because we have both the beta-1 and beta-2. Epi does both of those way better, way stronger, way more elevated, intensive response, kind of much more potent, so to speak, to use that term. Epi, we also get that alpha vasoconstriction. We don't really get that with albuterol, right? So that's one of the other kind of key kind of pieces between it is Epi will hit all three. Albuterol just hits the beta and primarily that beta-2, right? But if you compared an injection of Epi versus an inhalation of albuterol and looked at those beta-1 and beta-2 effects, that Epi response is going to be a lot stronger, right? A lot stronger for sure. All right. Cool. All right, so adult dose. Right. We added in just a couple more components. Right. Adult dose is very standardly 2.5 milligrams via SVN. So we nebulize it for them to inhale, or depending on your setup and equipment, you can put it in line with a BVM, where when we actually squeeze the BVM, we can force some of that albuterol in, right? But very classically, 2.5 milligrams is the dose, right? The actual amount of that medication. And if we were going to put it into a SVN, usually going to want to add, 2 or 3 cc's of fluid, like saline, to help just kind of stretch out that lifespan. Right? So when we hook up that SVN, we can nebulize all of that medication very quickly. Right? So we want to slow it down a little bit to make sure we're able to get more of that medication down into the lungs. If you were using CPAP for an asthma exacerbation patient, which used to be contraindicated in our textbook, but they've kind of started opening up that potential for CPAP with albuterol, you can actually put that SVN as an attachment into some CPAP masks and use that positive pressure airflow from CPAP to help force and push that albuterol down into the lungs. Really help get it deep down into the lungs, which is where albuterol is really going to work. And it's going to really start opening them up a lot better that way. Right. So adult dose, 2.5 milligrams. Between albuterol and Atrovent, which is the next one that we'll talk about, is, seems to be a lot more variable protocol to protocol. For you can do albuterol and repeat it once, but then after that, you need to call medical control. Or you can do albuterol 3 times and then call medical control. Especially once we add Atrovent in, that one seems all over the place. So certainly look at what your protocols are going to be, but ideally what we want to give it. Right? We want to give it early, and it works pretty dang well for a lot of people. If they aren't responding to it, that really starts to push us down decision-making pathway of just what else can we do, right? What other medications can we try? Do we need to kind of take over control of their airway and intubate the patient? Really just what are we going to do next? Really hinges off of how are they responding to the albuterol and the Atrovent for most people. Now, the reality is, certainly on the pediatric side, is pediatrics can take a lot of albuterol before we're really worried about any risk. Right? So look at what your protocol is, and then don't hesitate to kind of go down that med control route to say, hey, I've given my 3 doses of albuterol. We've still got 20 minutes to the hospital because we're in a further out area. Can I give more albuterol? Right? A lot of times you're probably going to get a yes on that, I would imagine. So adult dose is 2.5 milligrams. All right. I'll pause here for a second on albuterol and see if there's any questions that you guys have on this one. Atrovent will go a little bit faster because we already did the nervous system component for it. So I'll show you where Atrovent comes into play, and then the steroids will be quite faster comparatively. All right, so a question came through. If albuterol is not effective, is epi next? Depends on your protocol, right? Some places may have you try magnesium sulfate. Right? Others may say, let's do epi for it. Others may say, okay, if it's the SVN and the albuterol is not working, try it with CPAP, right? So pharmacologically, if the epi's really not or if the albuterol is really not triggering a response, if they're really starting to deteriorate, then there's a high degree of likelihood that we're going to go that albuterol route, or the epinephrine route for it. But kind of the sequencing of that is a little bit more variable. Maybe it's magnesium sulfate. All right, typical pediatric dose is usually the 2.5 milligrams for most places. Some, when you look at how albuterol is packaged, some may say half to start, but a lot of them will leave it at 2.5 milligrams as a starting route. But that seems to be one where maybe they let you do it once for a pediatric and then you need to call med control, or 3 times. That one's a little bit more up in the air from what I've seen on protocols. All right, so a question came through on contraindication. What does it mean synergistic with other sympathomimetics? Right? Synergistic means if they have one sympathomimetic on board already, and then we give them another one, right? The response is greater than both of them combined, right? So if we have a little bit of a response and a little bit of a response, we'll get a lot of response, right? They kind of heighten the response of both of them together. right? If we start mixing drugs, right? We give them one sympathomimetic and then give them another one, it's probably going to have an even stronger response than you would likely get. So like a double whammy. Yeah. It's like, hey, this one's kind of working, and then we give them this one and now like both of them are really working, right? It really, really heightens that response. All right. Good questions. Okay. So next up on our list, or really in conjunction with albuterol, right? Most of the time it's not we do albuterol first and then ipratropium bromide. Most of the time they get mixed together and then we run them together in one SVN. Right? A lot of people say a breathing cocktail, right? Or a duo neb, right? Is both of the drugs combined. So we're talking about ipratropium bromide, or much more commonly called, because it's easier to say, Atrovent. Right? So you'll hear a lot of people say albuterol and Atrovent, albuterol, Atrovent, albuterol, Atrovent. Right? So that's our ipratropium bromide. Right? When we look at that one, right, the class, we have the same word, bronchodilator, right, for class. Right? So it's telling us, just like albuterol told us, it's bronchodilation is what we're going to, is why we're giving it, right? What we're trying to achieve. We're trying to open up those lungs, right? So you can already start to see our indication is going to be the same. It's going to be the bronchoconstriction, bronchospasm, asthma exacerbation type patient, and we need to open up those bronchi, right? So bronchodilator is there, but where it's different is, instead of being a sympathomimetic, where it's mimicking the sympathetic nervous system, this medication is an anticholinergic, right? It's an anticholinergic. Right? And go back a handful of slides, and I'll show you where this one falls. All right. So we said albuterol is down here as a sympathomimetic, right? Or the adrenergic nervous system, adrenergic nervous system, right? So albuterol is on that side. The other side of this coin was that parasympathetic response, right? Which really kind of works against the sympathetic, right? And they're always kind of counterbalancing each other, right? So sympathetic, ramps everything up. Parasympathetic slows everything back down, right? Sympathetic nervous system causes bronchodilation. Parasympathetic nervous system can trigger some bronchoconstriction. Right? So just like adrenergic is another name for the sympathetic nervous system, the parasympathetic nervous system, another name for it is the cholinergic nervous system. Right? So those really are interchangeable. Right? Most of the time we say parasympathetic, but another name for it is the cholinergic. Right? This is a cholinergic nervous system. So Atrovent, we said its class was an anticholinergic. Right? An anticholinergic means it's going to be blocking that cholinergic response in the body. Right? So we just went through it. Beta 2 receptors, the sympathetic nervous system triggers bronchodilation. The parasympathetic nervous system, the cholinergic nervous system, can trigger bronchoconstriction. So by blocking the parasympathetic response, we're blocking that bronchoconstriction, which means it's actually going to help open up the lungs because it's going to allow that sympathetic nervous system to have its effect, which is bronchodilation. Right? They always kind of work against each other, right? Sometimes positively, sometimes negatively, right? So the cholinergic nervous system could actually be driving that bronchoconstriction. So if we block that bronchoconstriction, block that parasympathetic response, they'll open up, right? So an anticholinergic medication is achieving bronchodilation just by a different pathway in the body. Albuterol does it by directly stimulating the sympathetic nervous system. Atrovent does it by blocking the parasympathetic nervous system's response to it. Right? So we're really stopping that kind of balancing effect that's trying to happen, right? Because when we ramp up the sympathetic nervous system with albuterol, that parasympathetic nervous system is going to get activated to try to start balancing it out, right? Because our body is constantly adjusting and adapting, trying to maintain that homeostasis. So when that sympathetic response comes up, that parasympathetic is going to start to respond. So we want to block that parasympathetic response to really heighten and maximize that bronchodilation that we're achieving. Right? So we get bronchodilation just by a different route in the body. Right? It blocks that parasympathetic response. It does not trigger the beta-2 receptors. Right? It doesn't bind to those beta-2 receptors. It blocks that parasympathetic response to it. That's the anticholinergic, right? Which you could also say is an anti-parasympathetic drug. Right? Just another way of saying it, right? Because the cholinergic nervous system is the parasympathetic nervous system. So we're saying this is an anti-drug. So it's working against it, doing the opposite of, or blocking that effect, right? So that's how we're achieving it with our ipratropium bromide, is by blocking the parasympathetic response that's going to either be contributing to the cause of the problem in the first place, or at the very least is going to be responding to our activation of the sympathetic nervous system. So mechanism of action, right? Really looking at how it does it. It's what I just said, right? It blocks that parasympathetic response, which is really blocking, right, a big component of a lot of our stuff, which is a longer conversation for a neuroanatomy and physiology review day. One of the big kind of driving components of the parasympathetic nervous system is the vagus nerve. The vagus nerve is a big component of the parasympathetic nervous system. So the mechanism is actually blocking, inhibiting a lot of the vagal mediated responses, right? A lot of the things that the vagus nerve actually triggers and does inside the body, right? That's the parasympathetic nervous system, or a very big component of the parasympathetic nervous system. So saying it's an anti is saying it's an anti-vagus nerve, right? So it's kind of working against the things that the vagus nerve wants to do. That's whenever it comes up, I like to bring it out. We don't talk about cranial nerves too often, right? But the vagus nerve is one of those cranial nerves, right? And it's cranial nerve 10, which is X, right? Where they use the Roman numerals, right? Cranial nerve 10 is the vagus nerve. All right. Indications for us. Right? Indications, we said, is really going to be that same bronchospasm process. Right? So beyond just this patient's having a difficulty breathing situation, is we're seeing some of those signs of bronchospasm. Right? It's why we don't just say it's a difficulty breathing protocol. It's like, well, there's a lot of very, very, very different things that could be causing difficulty breathing. So we need to go a step further and figure out really what's causing the difficulty breathing, right? If the difficulty breathing that we have is because of an allergic reaction, anaphylaxis, that's a very different treatment protocol. Right? If it's a bronchospasm, bronchoconstriction, asthma exacerbation, that's all this stuff that we're talking about. Right? If it's a different cause of difficulty breathing, right? It's a foreign body airway obstruction, right? That's a very different treatment process as well, right? So it's not just every patient with difficulty breathing gets these things, right? It's when we think that the cause of their difficulty breathing is really a bronchospasm process, right? That's what's actually happening here. Alex, yes. To that question. Yes, it is. As long as you understand what it's meaning, right? Beyond just kind of rephrasing it, it's understanding what it means. we'll go further in depth into acetylcholine and everything on a later day too. But for now, we're blocking the vagus nerve, right, and a lot of the things that it can do. All right, so indications are bronchospasm. Right, adult dose is 500 micrograms mcg. So remember back to albuterol, it was 2.5 milligrams. Ipratropium bromide Atrovent is 500 micrograms. Now, if you're not used to the numbers or anything like that, they're off by a factor of 1,000 milligrams to micrograms. So 1 milligram is the same as saying 1,000 micrograms. Right? 1 milligram is 1,000 micrograms. Right? So it's just a different scale of units. Right? If you say 3 feet equals 1 yard, well, it's the same amount of distance, we're just using a different term. Right? So I can say 1 milligram is 1,000 micrograms. Right? It's just a different kind of unit scale of it. Right? So 500 micrograms is how it's most often written. Right? That's how you'll most often see it. But if we were looking at the math, 1,000 milligram or micrograms is 1 milligram. So half of that, 500 micrograms, is the same thing as saying 0.5 milligrams, right? Half of a milligram. Right? But most everything is typically phrased with Atrovent in the micrograms. Right? So it's 500 micrograms. Same thing, right? Mixed into an SVN, right? Or that SVN can be put in line with a BVM where we're actually going to help bag and force that or use that positive pressure air to help force some of that medication deeper down into the lungs. Right? Or same thing, maybe it goes into that SVN and there's that adapter piece onto a CPAP mask, again, just to help use that air pressure to deliver that medication down into the lungs. So most commonly, though, like I said, is when we get kind of that SVN chamber. Right? All right, and that's where we hook our oxygen tubing up, right? And then it nebulizes it, right? And that's the part that the patient breathes through, right? We put inside that chamber our 2.5 milligrams of albuterol and our 500 micrograms of Atrovent. Usually they're just mixed together into that nebulizer, into that SVN. And so when we pump that oxygen through there and it turns it into that mist, right, that's the mist that the patient is going to be breathing in. Right? That's where we're nebulizing that medication, right? Putting it into that kind of misting form that we can actually breathe down into our lungs. So we put both drugs in there because they're going to achieve, again, back to the nervous system split between sympathetic and parasympathetic. It's achieving bronchodilation 2 different ways inside the body. Right? It's another big reason why people say our SVNs work so much better than their metered dose inhalers, their puffers. Right? Like we said, our albuterol is usually a higher concentration than theirs, but then it's also coupled with the fact that most of the time we actually have 2 drugs in there helping to achieve the same response of bronchodilation. Right, so we put both of those medications very commonly. And again, you'll hear them say it's a breathing cocktail, or I believe it's a brand name is a Duo Neb, right? Duo 2 nebulizer neb. Right, so it's saying there's 2 medications in there. So that's a brand name packaging of both of those drugs are usually combined. Right? Otherwise, we'll just pour both of them into the SVN and then hook up the oxygen and run it through there. Most oxygen flow rates, 6 liters per minute is a very standard number that we'll hear when we're setting that oxygen through an SVN. A faster or a higher flow rate than that will really just nebulize that medication much faster, right? Turn it into a mist much faster and kind of burn off that medication, right? We want to make sure that patient has enough time to start breathing it in, because what will happen is it'll start opening up their lungs. And then as they keep breathing in more of that, it'll open up more of their lungs and more of their lungs and more of their lungs. And we start to get that medication deeper down into the lungs. So that's ideally. Atrovent Again, I've seen protocols that say for some patients, we're not even going to bother with the Atrovent. Other protocols, I've seen them say you can use Atrovent one time and that's it. You've got to call medical control. Other protocols say you can do it up to 3 times with the albuterol, and then after that, no more. It's up to medical control. So a little bit more, like I said, this difficulty breathing bronchospasm protocol is a little bit more variable protocol to protocol. There's not really as clearly kind of one clear-cut answer on what's standard for how many can you do, right? So always go back to the protocol when it's actual treatment time, which is pharmacologically, this is why it's beneficial for us to give both, is because we're getting bronchodilation 2 different ways inside the body. Now, another part that's very unique between these two is when we look at that whole respiratory tract, right? And we have our trachea, right? And then we have our big bronchi, right? And so we got big bronchi and big bronchi, right? So it's the 2 big pipes that split to go to the right lung and the left lung. And then those big branches, you know, start branching down into smaller branches, right? And off of those smaller ones are smaller branches, right? And smaller branches until eventually it gets all the way down to that alveoli level, right? Which is where all the gas exchange is actually happening to get that oxygen to the bloodstream and the CO2 out of the bloodstream, right? So the bronchi are the big branches, right? And then the tiny little branches further deeper down in there are the bronchioles, right? So beyond the benefits from the sympathetic parasympathetic nervous system response, we also see slightly different areas of the lungs will actually have that bronchodilation effect by the medications, right? So albuterol works a lot better, right? Deep down on the bronchial level. So much further down to the tiny little branches, right? Those smaller branches, that's where the bronchodilation from albuterol will actually happen. Right? Higher up in the big bronchi is where the Ipratropium bromide or the Atrovent will really start to work, right? So you'll get bronchodilation in the larger bronchi because of Atrovent, and bronchodilation on the smaller little bronchioles from the albuterol. Again, so it just becomes kind of benefit on top of benefit for why we would like to be able to do both of these drugs for the same patient. Right? Trigger the sympathetic nervous system, block the parasympathetic nervous system, dilate the big bronchi, and also dilate the little bronchioles. We're really trying to open up everything as much as possible so that the oxygen that we need to get in all the way down to the alveoli has a much easier time getting down to the alveoli, where it's then going to get into the bloodstream. And the carbon dioxide that's in the bloodstream, right, it's going to diffuse back into the alveoli, and we want to get the carbon dioxide out of the body. Right? So by having bigger pipes, right, there's going to be less resistance, right? With the bigger pipes, it's going to be easier to move that airflow back and forth, in and out. Right? So that's the benefit of the bronchodilation is opening everything up. Bigger pipes makes it easier for all that air to move in and out. Right? Cool. All right. Questions kind of initially, right? You know, we can spend a couple hours just on one single drug, getting into all the adverse effects and contraindications, but I really want to keep it just kind of to the initial core pieces of mechanism of action, the indications, the adult dose, really just how this medication is actually working in the body. Any questions on Atrovent? Asthma and a lot of the COPDs as well. Most of the time they'll kind of pull those into it for that difficulty breathing treatment. So yeah. Right. The last two, I actually talk about them together. Methylprednisolone and Dexamethasone. Methylprednisolone and dexamethasone. Both of them generically can be called steroids. Right? I know in like the drug profiles that we use, they use like glucocorticoid, synthetic adrenocorticoid, especially on the dexamethasone side. But very generically, we can talk about them as steroids, right? And that's going to work just fine for us. And with that steroid process, is we understand the effects that steroids have. And so steroids are anti-inflammatories, right? Inflammatory medications, right? So they're stopping that inflammatory response, right? Which is one of the very early responses of the immune system, is that inflammation response, right? Kind of hand in hand with that inflammatory response is usually a fever, right? When that immune system is getting activated, it starts heating up that system, right? So the inflammatory response is a very early effect that happens when that immune system is getting activated for whatever reason, right? There's some sort of allergen, there's some sort of antigen, some infection, right? Something triggers an activation of the immune system. One of the first things that the immune system does is ramp up that inflammatory response. So as an anti-inflammatory, we're saying we're going to block or stop that inflammation process, right? Which would mean we're also blocking or stopping some of that immune system response, right? So steroids, not really kind of truly used by us as paramedics in that capacity, right? But steroids are immunosuppressant medications, right? So somebody that's on, steroids for, they have some prescription for steroids for some sort of treatment process. Part of the factors of that is that we know it causes some immunosuppression, right? Because it's stopping one of the first phases of that immune system response, which is that inflammatory response. So somebody that gets a organ transplant, right, where they need to make sure that that immune system doesn't start to attack that new organ that got put in, right? They may be put on steroids to help weaken that immune system so that it doesn't cause that effect, right? So not really, again, why we're using it, right? But it does have that effect, right? Is some of this anti-inflammatory response. Another way to kind of look about it is if you think about just, you've got sore muscles, right? Your back hurts or whatever, right? You take anti-inflammatory medications, right? Like, Tylenol, right? But they are the class of those types of medications in our medicine cabinet are NSAIDs, which are non-steroidal anti-inflammatory drugs. So that's the same anti-inflammatory. This is just saying it's non-steroid. It's not a steroid, but it's still causing some of that anti-inflammatory. Okay? So we take a medication like that to help with sore muscles, right? Your back hurts or something like that, take some Tylenol, right? That's an NSAID, right? It's an anti-inflammatory, which is why it helps, right? It helps with those sore tissues. We're going to talk about that. It's just not a steroid, right? These two are steroids, right, that are causing that anti-inflammatory response. All right, so a question came through. To treat anaphylactic shock, would you use these steroids in addition to epi, or does it depend on protocol? You definitely can. It's going to be much lower down the treatment process, right? Epi is the wonder drug. It's the one everybody's going to go to. If we're dealing with anaphylaxis out in the field, we give epi. If they are dealing with anaphylaxis in the hospital, they give epi, right? So that's still the starting point. And then probably Benadryl, then maybe some other stuff. And then another thought coming down the road is one of these steroids, right? So it's absolutely appropriate and indicated. It's just a lot further down our treatment process as well. All right. So these medications, we talk about the mechanism of action. Right? We look at it from the standpoint of this anti-inflammation process of how it's actually stopping this inflammatory response. And one of the things that it'll get phrased as is the thought that it stabilizes cell membranes. Right? Stabilizes cell membranes. Right? So we have cells, right, that have fluid, right, the nucleus. Right? If you get into biology or cellular biology and they talk about mitochondria and Golgi apparatus and the RNA, all that stuff is in there. Lysosomes are in there, right? All of those different things are inside the cells, right? But one of the big ones is we've got the fluid, right? We've got fluid inside the cells as well. And in the inflammatory response, what happens is some third spacing of fluid, where some of that fluid leaves the cells, right? And it ends up, right, in some of this space between the cells, right? So there's little bits of space between all the cells, and some of that fluid stays in there, right? And that third space, right, that's where the term third spacing comes from, right? That third space is called the interstitial space. Forget it, interstitial. Interstitial, right? So the interstitial space is that third space. It's the space between the cells, right? So we have the space inside of cells, which we call intracellular space. And we have our bloodstream, right? That's our blood vessel, right? We have the intravascular space, just like we start an IV, right? Intravascular. So there's three spaces that fluid's located in the body. It's inside the cells, it's inside the bloodstream, or it's in the space in between the cells, right? And fluid's always in all of those spaces. Because when everything's fine, there's a certain amount that's inside the cells, which is perfect. There's a certain amount inside the blood vessels, which is perfect. And there's a certain amount in between the cells, which is perfect and just fine as well, right? In the inflammatory response, though, we said a lot of that fluid starts to kind of seep out of the cells into this third space, right? So there's less fluid inside the cells and there's more fluid inside the interstitial space, or inside the space between the cells, really just into the tissues, right? And that's what we get, is we get fluid leaking out into the tissues, and those tissues start to swell, right? That's what we say when we call it edema, right? Is the tissue is swelling, right? Well, that swelling of that tissue, the swelling is happening is because that fluid is seeping out of the cells into the tissue, right, into that third space, and that's causing that tissue to start swelling. So where this relates to us for this asthma exacerbation, bronchoconstriction process that we have, right, is really going back to that idea that we said, you know, kind of down the length of our bronchi and bronchioles, right? We have those smooth muscles that are there. Right? And those bronchial smooth muscles constrict or contract. And really what it is those bronchial smooth muscles are swelling, right? And that swelling is causing the bronchoconstriction. Right? So it's the actual fluid, right? Like we were saying, fluid leaving the cells going into that third space. Right? When that's happening on these smooth muscles that are wrapped around our bronchi and bronchioles, right? That fluid starts shifting, those bronchial smooth muscles start swelling, right? But it's an enclosed container, right? So when it starts swelling, it starts constricting the size of that pipe. Right, so that's what's going on in that inflammatory response, is the inflammation of that respiratory tract, the inflammation of those bronchial smooth muscles, right? That got triggered by whatever triggered that person's asthma, right? Or allergic reaction, whatever it is, triggered that inflammation, triggered that fluid shifting to happen, which are those bronchial smooth muscles are swelling, right? And as those smooth muscles swell, it starts closing in, right? And closing down on the bronchi and the bronchioles. So when we come along and we give steroids to stop that inflammatory response or block that inflammatory response, that's going back to our cell that has all that fluid in there. Right? Steroids, we say, stabilize, right? Stabilize the cell membranes. Right? So that way, fluid doesn't leak out. Right? And if fluid doesn't leak out of the cells, those bronchial smooth muscles don't ever get the edema, and they don't ever start swelling and then closing off the pipes. Right? So by stabilizing cell membranes, we're stopping the third spacing of that fluid. We're stopping that fluid shifting from happening. Right? So it's kind of like fortifying the walls of the cells. Right? If your cell was a bank and somebody kept stealing money from the bank, right, you would ramp up your security. Right? You'd ramp up the fortifications, right, to try to stop that money from, being taken out of the bank. It's the same thing here with the steroids. They're ramping up the security, ramping up that perimeter to stop that fluid shifting, right, to stop that fluid from leaving the cells. And again, if the fluid can't leave the cells, these bronchial smooth muscles don't ever swell, and they don't close off the bronchi and the bronchioles, right? So we're stopping that fluid shifting from happening. So the indications when we look at them on a lot of drug profiles is they'll say reactive airway disease, right? Which is saying the airway is reacting to something, right? Like a lot of, allergic reactions, right? And, those seasonal allergies and asthma, right? Something triggered that bronchoconstriction process, triggered that activation of the immune system, triggered that inflammatory response, right? It's a reaction to some sort of trigger, right? Like I know come March, April, seasonal allergies here hit me, right? I get miserable in April for seasonal allergies, right? It's a reaction. That's my immune system is reacting to the tree pollen or whatever it is that's actually, triggering that allergic reaction. Right? So reactive airway disease is kind of a broad umbrella category. It can be anything. It could be allergic reactions, could be asthma exacerbation. That's a very generic term. Another one, anaphylaxis. Okay. Anaphylaxis, or broadly allergic reaction. Again, like we said, though, that one's going to be much later down our treatment process, right? Epi and some other stuff will probably be coming first on that one. But again, one of the things that happens in anaphylaxis is a big third spacing of fluid, right? In the lungs, but then also in other places, right? Just like you can have that angioedema. Have you ever seen somebody with that angioedema where their lips and their tongue, everything swells open, right? It swells really big. That's the fluid shifting, the third spacing that's happening, right? Or if you have an allergic reaction, like a topical allergic reaction, and gets, the hives that's there. Well, hives are showing up because that fluid is shifting out of the cells into that tissue right there, right? So that's our reason for it. Is again, it still goes back to stopping that fluid shifting from happening. Another one that we have is burns involving the airway on here. And again, same thing, right? If we get burned down that respiratory tract, one of the huge things in burns anywhere on the body is big time third spacing of fluid, right? So when we get that burn involving the airway, that airway is going to swell shut pretty quickly because of that fluid shifting fluid shifting. And there's only so much space that we have up there before it's just going to close off entirely, right? So stopping some of that fluid shifting from happening is going to be a very beneficial thing. Right? So those show up on our methylprednisolone, right? All three of those. On the dexamethasone, it's really the same reactive airway disease, the same anaphylaxis. And then another one that sometimes they add into it is cerebral edema, right? Non-traumatic cerebral edema, so not be caused by a head injury. Right? And again, this one's in the name, right? There's edema that's happening. Fluid is shifting into the tissues. In this case, it's into the brain. And cerebral edema is fluid is shifting into the brain. So let's stabilize these cell membranes and stop all of that extra fluid shifting from happening, stop the edema from continuing. Yeah. If you ever watch any of those movies, like the Mount Everest documentaries or the like Hollywood versions of Mount Everest climbing movies or mountain climbing movies, a lot of times you'll hear them talk about in there, they'll be taking pills, right? And the pill that they're taking is dexamethasone, right? Is a steroid. And one of the things that they're doing it for is to try to prevent cerebral edema and pulmonary edema that can happen when you climb up to, you know, crazy high altitudes. Right? So they're trying to prevent that. Another place, a little bit more commonly right now, is a lot of patients with COVID are given, I believe, pretty high doses, but I'm not 100% sure on the dose, but a lot of patients with COVID are given dexamethasone. Again, it all becomes the same kind of redundant reason. Let's stop that inflammatory response. Let's stop the fluid shifting that's happening into the tissues and those tissues that are swelling, right? So dexamethasone is a big one on COVID treatments right now. All right, so I'm just gonna put M there for methylprednisolone because I'm tired of writing it, and D for dexamethasone. So brand names that are much more common for methylprednisolone is Solu-Medrol, and dexamethasone, a pretty common brand name, is Decadron. Right? So very interchangeable in terms of it. I know for us here, most of us, we have Solu-Medrol, right? But if there was ever, you know, a national shortage of Solu-Medrol, maybe we'd be given Decadron instead, right? So a lot of them are very interchangeable. Which one you have, if you've got both in your drug box, which one you use, probably going to be dictated by your protocols, right? But if you don't have a protocol that says use this one versus that one, then you could pick, right? You could choose which one. More commonly is the Solu-Medrol for sure. And our dose for that one is 125 milligrams, right? Slow IV push, right? Slow IV push or slow IV bolus, right? So usually we're administering that medication over a couple minutes, right? 2 to 3 minutes is a true proper slow IV push. Decadron, right? Dose for Decadron is a lot more commonly in the 8 to 24 milligram range. Same thing, you can give it IV, you can give them IM as well, but ideally, right, for this difficulty breathing patient, we'll get them IV if we can. But some of those you can give different routes. One of the big kind of key things for, you know, what came up, and Rich actually answered the question in the chat, which I appreciate, is, you know, will we give this, you know, for anaphylaxis? And if so, where do we give it? And these drugs, these steroids, are pretty much always like the last drug that we're going to give. Okay? It's kind of in that territory of like, what else can we do for our patient? Well, let's give them one of these steroids. Okay? And it really gets down to the onset of action, right? Which is really, when does the medication start to work? Right? When does it really start to work? And Solu-Medrol will start to work in 1 to 6 hours. 1 to 6 hours. Decadron is a little bit worse even. Okay? It'll start to work in 4 to 8 hours. Okay? So we got to think about, I mean, anaphylaxis is a true rapid emergency. So we got to get epinephrine in the system right away because that's going to help. Okay? And then we're going to try Benadryl. We may try a bunch of other drugs, right? Solu-Medrol is not going to be the savior of our day for anaphylaxis, because that anaphylactic patient, if we don't stop that problem, they're going to be dead long before 1 to 6 hours or 4 to 8 hours. Right? So it's after we kind of get ahead of the game with our other medications that we can get one of these on, right? Knowing that for most of us in the pre-hospital setting, we're not continuing to interact with this patient for 6 hours or 4 to 8 hours, right? So that patient care has probably already been handed off to somebody else in the hospital. So we really look at getting these medications on board, because the sooner we get them on board, the sooner it'll start to take effect, and the sooner the patient will get the benefit of it. Just we're probably not going to be there for when they really get the benefit of it, right? So we're just trying to get that treatment on board to help the hospital staff, a little bit later, help the patient, obviously, primarily, but not really for us pre-hospitally, at least for most of us. So when you look at these onset of actions and peak effects and durations, it's super critical information, because you have to know, you have to be able to understand, am I giving this medication and I administer Solu-Medrol, and then 5 minutes later, okay, how do you feel now? It's like not any different, because we need, at minimum 55 more minutes before it's actually going to start doing anything, right? So it's also, looking intelligent, when we're in school and we're doing paramedic clinicals or vehiculars or working as a provider later, is obviously understanding we're giving this medication and we're not looking for a response in the near future. So it's not really one of those that's like, okay, how do you feel now? It's like the exact same, right? That medication's not working yet. It doesn't work that fast inside the body, right? It takes some time to get there. All right, so that's one of the key parts with the steroids. It's just that onset of action time frame is so long, right? So long for us that it doesn't benefit us as much. All right. Again, that's kind of the best kind of initial basic starting point for these medications. Like I said, we could do hours just on single drugs and get through, everything on the drug profiles that we use. Even more so if we got into kind of textbook drug profiles or the true kind of US pharmacopoeia drug profiles. We'll just have a laundry list of different things that we can use them for, right? These steroids are used for a lot of things, right? Because we really carry them for like 3 reasons. And it's mostly the difficulty breathing, reactive airway disease, asthma, and then the allergic reactions. And then not too commonly are we running across burns involving the airway or cerebral edema or any of those other kind of weird fluid shifting problems. Most of our use of this is going to be on the respiratory side, right? On the respiratory side, that difficulty breathing side of things. All right. So if we were looking at it, if we took an asthma patient, because I know I do weird madness and I'm all over the place when I talk about drug profiles. So let's kind of put it back into a box, right? Is we've got our asthma patient, right? We're going to do our normal ABC assessment, right? And put them on oxygen, right? O2 IV and monitor. Right? A couple of you are in the new side of the paramedic program. In EMT school, it's BSI scene safety. In paramedic school, it's O2 IV monitor. Right? Everybody goes O2 IV monitor. Right? So that's a common one. Right? We're going to at least get just that basic starting point down. And then after the rest of our assessment, once we've kind of landed on that idea that our patient is having an asthma exacerbation, right? The first thing that we'll do next, right, will be that Albuterol, Atrovent breathing treatment. 1, 2, 3 times, whatever protocols allow us to do. And that's 2.5 milligrams and 500 micrograms, and these are via SVN. If they start responding to that pretty well, awesome, right? Then maybe the next thing that we do is one of our steroids. Right? We got the time, sure, let's get it on board. Right? If they're not responding to it, then some other drugs that we'll cover, in coming weeks and in the programs, we'll cover magnesium, right? Some places allow magnesium sulfate to be used for the asthma exacerbation. That epi, we said potentially as well, could come into play for it. So it really starts to depend, but pretty much everybody is going to have you starting with that albuterol Atrovent, and let's see how they do. Right? If they start to get a little bit better, well, then maybe we do another round of albuterol Atrovent and see. If they get a little bit better on that one and our protocols allow it, maybe we do a third round of albuterol and Atrovent. Right? If we're trending in a good direction, we're probably going to let that happen. It's when our patient's not responding to those medications or they're getting worse that then some other medications come into play. Maybe it's magnesium, maybe it's epi, right? And then once we kind of feel good about the direction that we're headed with our patient, let's get one of those steroids on board too. Knowing again that that one's the hours later, effects that we're going to see there. So one of the biggest recommendations I can make for a lot of paramedic students, especially early in drug profile learning and studying, is, we've got these sheets and then books and everything, and we're memorizing all this random stuff and we don't have any context for it. I encourage you to memorize it and look at it and study it from the drug profiles, but then get your hands on a set of protocols and see how it actually fits in order. Right? A lot of paramedic students benefit by seeing the context and seeing I do this drug, and then I do this drug, and then I do this drug, as opposed to us studying and say, okay, well, I've got 4 drugs right now that can all be used for this. So what the heck am I going to do first? Right? That's where the protocols will come into play for.